Hamid bhai.
Ashok, I think it's working.
Yes, it is working.
Yeah, thanks. Arif, we are live now. I'm making a back host. Okay. Dr. Arif? Arif, unmute yourself.
Yes, sir. Yesterday we have some problem with the live streaming.
Now we are live now. You can start.
Yes, sir. Thank you, sir. I am waiting for the presenter today. He is still to join. You know that yesterday we have some problem regarding the connection of live streaming, but today we solved. Thank you, Samsuludha sir, and thank you, Ashok Sham sir, for doing this job for us. And I am waiting for Hamidul Islam, today presenter. And you know that this is an initiative by Bangladesh Kurgan Fellow Group, and Bangladesh Kurgan Fellow Group organized this lecture with a very frequent gap, and usually we have 24 lecture, and we will stop. We will end our session on 24th of this month, and that session was will be a little bit a big session. Several presentation will be there, and you will be happy to know that tomorrow there will be very big day for us. Junjunala sir will be back again with his experience, and two lecture on that day. One is on congenital pseudoarthrosis of tibia, and other is the aseptic non-union of tibia. So I invite you all to be please present tomorrow and have some good experience sharing platform in Bangladesh Kurgan Fellow Group webinar. So I am waiting for the presenter today. I want to make a call.
What is the topic for today, Dr. Arif? Dr. Arif, what is the topic for today?
ILIZAROV Pintact Care, sir. ILIZAROV Pintact Care.
Okay.
And lecture 17 today. Hamid bhai. Ki we are waiting for the host, and in the meantime I request Professor Bari sir, please you can have some words for us before the speaker joined with this forum. Bari sir, can you hear me?
I can hear you.
Yes, sir. Please have some
so much young.
Assalamu alaikum, everyone.
Walaikum salam.
So today it will be our 17th lecture.
Yes, sir.
And accordingly, step by step, we are proceeding. And we are going to finish on 24th.
Yes, sir. Hopefully.
So tomorrow, Professor Junjunala will speak on non-union and CPT. Okay. And today, Hamidul Islam is going to talk on pin track care. It's very good.
Yes, sir.
So all the best. I see Ghulam Farooq is here, Adikulli is here, Mustafa is here, Abdullah, Shetu, PRS, Safi Jaman, Shalom. Oh, a lot of people already.
Hello.
So,
sir.
Yes, sir.
Oh, I was absent for the last two sessions.
Yes, you are absent.
Yes, I have a family problem. Unfortunately, one of my second daughter, our little daughter, was COVID positive. He's in isolation. Please pray
Now,
for him. Pray for her.
oh, okay.
He's
Clinically
symptomless. He's not.
symptomless.
He's
Okay.
totally symptomless. We have some agony also. Yes.
Inshallah, everything will be okay.
Inshallah.
Don't worry.
Yes.
My son was also. You saw, my son was also COVID positive, Dr. Shayan, and symptomless. Everything.
Symptomless. Like my daughter.
Now he's okay. He's working, doing duty in Bangladesh Medical. No problem.
Okay. Thank you, sir.
Sir, we're very sorry to hear that some of our very close relatives are getting COVID positive. We all pray for them and hope they are early recovery. Now our speaker is online, and Dr. Hamidul Islam, can you hear me?
Yes, I can hear you.
Yes, he's here.
Can you hear me?
Yes, sir. Arif, you can start now.
Yes, sir. I can start now. And okay, you know that today our 17 presentation, L17, and today our presenter is Dr. Hamidul Islam. He is one of our Kurgan fellow, and he is working as a assistant professor in Nitor, Bangladesh. He is very experienced and a renowned ILIZAROV surgeon in Bangladesh. And now I am asking Dr. Hamidul Islam, please share your screen, and so that we can go to the presentation.
Okay, thank you, Dr. Arif. Can you hear me?
Yes, sir, we can hear you, and please do the screen share. And for your information, that today Mustafa and Samsul Huda as usual, Nazmul Huda as usual is co-host with me. Please do the co-host job when you have the need to admit person for the attending the session. Okay, Hamidul Islam, we can see your screen and slide presentation. You can start from the beginning.
Okay. Can I start?
Yes, please start.
Okay, thank you very much, Arifud Jawan, and thank you to all, and welcome you all, everybody all, to the basic ILIZAROV session from Bangladesh Kurgan Fellowship Group. Today, your topic is our pin tract care. It's very important, I think, pin tract care. And there is a paper published by our legendary professor, respected Sir Bari sir, Tract infection ILIZAROV technique, how to manage that. It is published in 2017 in Medcraft American Journal, and sir elaborately describe everything there nicely. I think if you go through this paper, you will come to know many things. Thank you very much, sir. And what is pin tract care? Actually, there is no accepted definition of pin site infection universally. Pin site care is a dressing procedure used to reduce the incidence of infection in patients undergoing treatment with an external fixator. And what are the aims of pin site care? The aims are to provide a standard guideline for the nursing staff and improve the patient experience of the procedure, to minimize the risk of pin site infection and complications, to ensure aseptic environment for pin site care, clarify escalation process in the event of pin site irritation and infection, and to provide principles to support education of patients and their family. And there are some risk factors of pin site infection. What are the risk factors? There are two types. That is patient factor and fixed related factors. Into the patient factors, the factors are increased patient age, infringing medical comorbidities, that is diabetes mellitus, rheumatoid arthritis, other cardiovascular diseases, and use of steroid. Smoking, my dear, smoking is very important factor which may cause pin site infection. Excessive patient movement and traumatized activity, traumatized skin. There are other factors, external fixator parameters, that is increased duration of pin fixation, periarticular pin displacement, sites with greater soft tissue size, with greater soft tissue thickness over the bones. If there is huge soft tissue around the bones, there is evidence of pin site infection. Skin tension around the pin site, faulty pin insertion technique, inadequate fixation of pin. Now, what are the types of pin site infection? Basically, there are three types of pin site infection. That is pin site reaction, pin site colonization, and pin site infection. What is pin site reaction? If you see the arrow here, represents normal physiological changes in the skin color. Skin may be warm and pin site drainage may be little or no. Resolve within 72 hours. What is pin site colonization? It includes erythema, warm, drainage, possible pain, and positive culture. And what is pin site infection? This arrow is indicating here, includes all of the above, possibly with addition of pus, pin loosening, or increased microbial growth and culture. For the complication of pin site infections, some pin site infections are complications. So severe problems may follow that could compromise treatment goals and increase patient morbidity. This includes pin loosening with loss of fixation, loss of alignment, and frame instability, joint or fracture site contamination, increased pain which limits patient function, the risk of intermedullary infection increased, and there is chance of development of osteomyelitis. See the picture. This is there is pin loosening of the pin. There is erythema and pus loosening of the pin. And this picture shows the ring septum. After removal of the pin, there was loosening of the pin. There is ring septum. There are more examples of pin site infections. And some evidence for prevention of pin site infections. Although pin infections are a common complication of external fixation, there is no consensus regarding the optimal measurements that should be used to prevent them. The variations in surgeons and nursing preference are in part due to limitation and gaps within the current literature. Specific limitations include adequate paucity of randomized control trial, meta-analysis, the lack of control groups in many studies. Randomized trials evaluate different variables, cleansing solution, dressing type, frequency of cleansing, making it difficult to discern the effect of any one variable in the event of a positive result. And regarding pin design and wire design, attention has to be placed on the development of materials and specialized footing of pins and different good quality wires that could potentially reduce rates of infections. Examples include titanium pins and hydroxyapatite footing. They said that titanium is thought to improve metal pin interface by inciting a smaller inflammatory response than the stainless steel. And hydroxyapatite enhances osseointegration of the pin, decreases motion at the interface, and lower the loosening rate, which would otherwise be a major contributor to infection. And this picture shows different types of pin, different diameter, different lengths, and dressing. And it is shown here that if we see that more the diameter of the pin, more the chance of infection. In one literature, they have shown that if you use the larger diameter pin, there are more chance of pin site infection. But if you use the like ILIZAROV wire, this is biocompatible wire, wire, there is less chance of infection. So see the picture here. This is biocompatible ILIZAROV pin or wire, and this is the large size pin. Just compare these two. There is more infection than this one. So you should keep in mind. Always try to use the biocompatible ILIZAROV wire. When necessary, we can use the shunt pin or other pins. The surgical technique is very important. Surgical technique is put it essentially as a means of lowering the incidence of infection rate. The goal is to prevent the injury of the bones and soft tissues and subsequent bacterial colonization of necrotic tissues. Intraoperative precautions such as protecting soft tissues with drill slips, using sharp drill bits, good quality wires, avoiding thermal necrosis when using power drills, and preventing ischemic necrosis of the skin by implanting wires of pins without excessive skin tension are all measures thought to be reduced pin site infections. And this figure, you can see here, this is the cooling the drill while pre-drilling is done. This is nice picture is here. And this aseptic technique of Barisar details told in his letter in his paper. And this is our Dr. Kamrujaman, surgeon in Kurgan Center. And this is the deal with in the aseptic. So gospel soaked with chlorhexidine solution and is drilling, aseptic drilling. And there is a procedure. This is the pulse drilling, that is stop and start, not continuous drilling, not high speed drilling. High speed will be low and stop and start. This pulse drilling is essential to minimize or reduce the pin site infection. Regarding tourniquet using pre-drilling during wire insertion will decrease blood flow to the bone and soft tissues, preventing blood from naturally cooling bone. That is, blood has cooling effect on the bones. If we use the tourniquet, this effect will hamper, and there may chance of development of thermal necrosis and ultimately pin-tech infection. And hematoma formation is associated with greater rate of infection. So, my dear, it is very important when we insert the wire. Just see here. While we insert the wire, we will just immediately after inserting if we push, if we keep a rubber stopper and push and contact with the skin, and when we use the olive wire, there is a small cut is there. So we'll use a gauze under the rubber stopper. If we do that, there is less chance of hematoma formation, less chance of pin site infection. This is very important and should keep in mind. Regarding cleansing solution, there are a lot of cleansing solutions. Many investigators have attempted to determine the efficacy of different cleansing solutions, reducing the rate of pin site infection. Different solutions like chlorhexidine, normal saline, high-strength hydrogen peroxide, 70% isopropyl alcohol, and soap with water. And the frequency of pin site cleaning. The optimal frequency for pin site is unclear. This is still not debate. How is the frequency of pin site cleaning? It may be done daily, 2 or 3 days interval, or weekly. One randomized study concluded that weekly pin site cleaning is appropriate as there was no difference in pin site infection and infection severity, antibiotic and analgesic use between daily and weekly cleaning groups respectively. That is, if we clean the pin site weekly or daily, there is no difference between these. Dressing types. Does dressing type of pin site dressing influence infection rate? There is still no debate. Lee and colleagues determined that pin infection rate was lower in patients with a polyhexamethylene biguanide dressing as compared to dry gauze. This is dry gauze and this is gauze soaked in betadine solution. And some other concluded that 1% silver sulfadizine dressing reduces the pin site infection in traumatized patient. Chlorhexidine impregnated patch may be used, some are using. 10% betadine gauze, white paraffin ointment, this is cohesive ointment, some are using for the dressing type. Polyvinyl pyroledone iodine soaked gauze may be used, sometimes Zeroform dressing, but randomized trials have been shown that no dressing type has shown to be superior to others. Regarding showering, whether the patient will take shower or not, there is still a debate, lot of debate. When patients may shower or bath post-operatively with the intent to reducing the pin site infection, there is little direction from the literature. One case series suggested that showering after post-operative day, that is on 5th POD, is not only acceptable, but also be used successfully as only the means of pin site care. Some authors concluded that daily showering was adequate as the sole measures for pin site care, as all infections resolve for oral antibiotic. This type of showering is not advised, but you may take shower in that way. You should not put your leg on the water. Regarding prophylactic antibiotic, oral antibiotics are often prescribed for prophylaxis against pin site infection, but evidence-based guidelines are lacking. Some authors say that use of oral prophylactic antibiotics for 2 weeks post-operatively may reduce the infection rate nearer to 40%. Another study showed that single prophylactic perioperative antibiotics is adequate to control pin site tract infection. In addition to oral antibiotics, some are used local administration of antibiotics. This is on hypothesis still now. What are the other factors that may reduce the pin site infection? In addition to the factor discussed above, there are other aspects of pin site care or operative technique that may affect infection rates. There are no control studies that address whether to use sterile or non-sterile technique when administering pin site care. There is an uncertainty about the effects of pin site massages to relieve skin tension, whether dressing are advantageous in comparison to no dressing, and whether to remove pin site scar. But it is advisable that we should not remove the pin site scar, because if we remove the pin site scar, there is chance of pin site infection. There is a criteria, that is a data, there is a grading system which is very important. If we know this very nicely, then pin site care management will be easy for us, I think. And in this grading system, and all treatment are included in grading system. This is Checkers and Otterburn criteria for pin tract infection. It is divided into 6 grades, 1 to 6 grade. For minor infection, 1 to 3, and major infection 4 to 6. What are the minor infections? That is slight redness, a little discharge. How to treat? Just improve pin site care. At grade 2, redness of the skin, discharge, pain and tenderness in the soft tissue. How to do the treatment? Improve pin site care and start oral antibiotics. And grade 3, grade 2, it includes grade 2, but no improvement with oral antibiotic. What should be done? Affected pain or pains recited, and external fixation can be continued. And in the major infections, grade 4, severe soft tissue infection involving several pains, sometimes with associated loosening of the pains. What should be done? External fixation must be abandoned. And grade 5 included grade 4, but radiographic changes. What should be done? External fixation must be abandoned. What changes is there? If we do the X-ray, we will see that the lucency around the pins, this is radiographic change. You can see if we do the X-ray. And grade 6, infection after fixator removal, heal. Pin tract heals initially, but will subsequently break down and discharge in intervals. Radiograph shows new bone formation, sometimes sequestrum. If there I have shown in one figure, if sequestrum is there, you must treat it as a pin tract size. So this is very nice criteria for pin tract management. What is done in Kurgan Center? What are they doing? The Russian technique consider the following: non-touch handling wires or pins, pulse drilling. I have already mentioned. Stop start with irrigation. This is must. This is very important. Removal of the bone particles, bone swab. This is come after drilling. Immediate pin site dressings in alcoholic solution with chlorhexidine with pressure to reduce hematoma. Dressing changes at completion of surgery if blood stain. Cleaning of pin sites daily for 3 days with a solution of 70% alcohol. Occlusive pressure dressing after the 3rd day. Pin cleaning and dressing changes repeated every 7 to 10 days. And see how much they take care of the patient in the operation theater. After the insertion of the pin, there is a rubber stopper, and when they're using the olive oil, there is a small cut in the soft tissue. They immediately after they just put valves in the dressing, and after finish of the surgery, they are doing nice dressing in the operation theater. And this picture will show us that in the center they didn't allow anybody, even patient attendance, for dressing. Only the expert people are doing the dressing with adequate aseptic measure. That is, with even they did not touch by their hand the pin side. They always use 2 arterial forceps or 2 tooth forceps for removing and dressing of the pin side. This is very important. And sometimes they're using this type of coverage for preventing the infection. And there is more example like that. How nice looking the dressing. And what we are doing in our management. We prevention of infection protocol. What we do, what we are doing. We usually we give intravenous antibiotic prior to surgery and continue for 24 hours post-operatively. And we continue this antibiotic orally for another 2 weeks to 14 days. And tourniquet sometimes we can use. And for skeletal traction, we are using 4.5 or 3.5 sunspins. And for ILIZAROV surgery, we are doing 1.5, some maximally we use 1.8 millimeter of different ILIZAROV wire. But electrocautery is avoided. This is very important. We should not do it at the pin side, because if we do it, there is every chance of development of pin side tissue necrosis and pin side infection. And patient care starts on second POD. A pin care is done 2 or 3 days interval by cleaning each pin site with a newly sterile gauze soaked with hexisol chlorhexidine, and dry gauze is wrapped around the each pin site. Showering is encouraged on 14 POD. When patient remove the dressing, allowing water to rinse the frame, the leg and frame are patted dry with a clean towel. Most patients are allowed to weight bearing as tolerated. When the patient present with the infection, what we are doing? We encourage the patient to start twice dressing the pin site and reduce activity and weight bearing and start oral antibiotics. If the measure fails, what we do? A reduction of weight bearing activity in conjunction with elevation of the limb if there is swelling, if there is erythema. And when inspection doesn't resolve completely, pin culture are taken and the second antibiotic are added empirically. Culture specific antibiotics are then started when results become available. For persistent infection, radiographs are obtained and evaluated for pin loosening. If pin loosening is not clear from the radiograph, the pin is then disconnected from the frame and then tested. Very easy. Just loosen the nut for the fixing bolt and just feel the pin for whether it is loosened or not. Loose pins are removed immediately. We are doing that. Loose pins removed immediately. Persistent infected tension wire also removed. When vital pins or wire are removed, the patient is brought to the operation theater room and modified urgently the frame. At that time, we also debride the pin site, infected pin site, and accompanying cellulitis, and patients is sometimes admitted for IV antibiotics and elevation. Patients who have had deep infection, that is loose or infected pain with lucencies on X-rays, are monitored for osteomyelitis. Typically, it is very important that removal of foreign bodies is enough to cure the infection. So if you think there is loosening of the pin site, there is chance of osteomyelitis, just remove the pin and do care adequate, taking measures adequately. After treatment, the external fixator, that is when we remove the fixator, we always debride the pin site or clean the pin site adequately. And some of our examples, we are using the hexisol solution. This is a dressing, nice dressing. There is no blood with any other material. This is our one patient. There is no pin site infection here. Let's see. Here, this nice dressing the patient. And boost effect, very important, very interesting matter. What is this thing? It is a very interesting matter. We have seen during our training period in the Kurgan Center. They have laboratory studies of tissue fluid. Tissue fluid from where? Tissue fluid from tension wire. They are taking tissue fluid from tension wire and comparing with the antibiotic monomycin. This is the diagnostic dish. What are they comparing? The growth inhibition of the tissue fluid and the bacteria and the antibiotics. They are taking an antibiotic and their tissue fluid. 2 to 5 probes are using tissue fluid. It is shown that after 30 to 56 hours, the tension for that is fluid that is used from the taken from the pin side. It has growth inhibition effect is similar or more than the antibiotic. This is very interesting. If they are taking fluid from the tension side, I put 3 probes and in a disease disk, and it's comparing with the monomycin. That is monomycin, the antibiotic. And it is shown that after 30 to 56 hours, turning of the tension forces, this equivalent or exceed antibiotic effect. Very interesting. And now in conclusion, pin site infection is very common complication of external fixation. In an effort to prevent or at least minimize this complication, the pin site strategy should be adopted, and that aspects associated with the pin site loosening and infection. This will include understanding of the external biomechanics, materials, and surgical techniques during pin and wire insertion, and a standard post-operative pin site protocol. And thank you all. See the picture of these two beautiful kids. Very small. I think they are not harmful for anybody. So if we use biocompatible ILIZAROV wire, this is very fine wire. If we use in our practice, if we use in a ring construct, I think we'll be safe because there is less chance of pin-tag infection. So use biocompatible thin ILIZAROV wire. Stay safe. Stay home. Stay safe in the pandemic of COVID-19. Thank you all again.
Thank you, Hamidul Islam. I request please stop your screen share so that we can go into gallery view. And today the topic pin tag care. Originally the pin tag term comes from the shunt pin. In ILIZAROV surgery, it is wire tag care, but the pin tag care, the term is very much popular, so we use this term. And I think this is a very good platform to discuss about the what is your pin tag care. How can we idealize? How can we make a reference to have the pin tag care? Because the caring of the wires in ILIZAROV operation and a very long time for post-operative period is very much important for your good outcome. And I especially thank Hamidul Islam for bringing us this issue and to collect many of the literature and also the different views about the pin tag care, and also the problems associated with the shunt pin and ILIZAROV wire issue, and how to care and where the infections are very much problematic in our day-to-day practice. Now I want to hear the experience of pin tag of his own practice, and what is the Kurgan recommendation and what are other experience. And just now I am going to, as usual, to my Professor Mufakkarul Bari to have comments overall the session, and then we go directly to different participants for their pin tag measures and other relative important issue. And if you have any question, please send it to me in chat box, or you can hands up so that we can go for the question answer session. Also, I'm seeing that
Dr. Arif,
hands up already. Yes, sir.
Can you বারি স্যার আগে একটু কথা বলতে পারি? বারি স্যারের দেওয়ার আগে আমি একটা কথা বলতে চাচ্ছি।
Hello.
Thank you, sir.
Yes, sir. Yes, sir. You can do, sir.
A question to Bari sir also. Mr. Hamid, yes, it is a very nice and excellent presentation. I appreciate you. You mentioned all the corners of pin tag infections. Pin tag infection is a common complication. It is a very much common complications in your daily practice in external fixator, and also ILIZAROV and other things. But have you any idea or any kind of study about the quality of our K-wire or olive, which we generally uses in our country? Probably most of it is made from Bangladesh, India. Suppose there may be some role about the quality of the implant. This question also to Professor Bari and also to you. Have you any kind of idea about that? Understand?
Can you hear me? Hamidul Islam, can you hear me?
Yes, I can hear you. Yes. Can you hear me?
I think, yes, sir, we can hear you.
Okay.
My question is,
এই তোমরা এই
About
পাশে
the
যাও না
quality
বলুন।
of our pin.
Sir.
Is it related to the quality of the implant? Wires?
Yes.
Yes, sir.
There is a
Yes,
question.
actually,
And we-
this is related to the quality of the wire. We have seen in the Kurgan center, they are using very nice wire, very nice, good materials of wire. But the wire we are using in our country, that is wire, it is not good quality wire. And regarding so if we use the good quality wire, then there is less chance of infection. Regarding use of K wire and olive wire,
Yes.
sir, there is debate still now. We have seen in the Kurgan center, some of the professors are saying that don't use the olive because it may cause it takes more bone pin interface, and there is chance of more infection. As there is olive in the we use the
Hello.
metal.
Hamidul
Hello?
Islam, can you hear me?
Yes, sir.
Okay, I think we got disconnected with Hamidul Islam. And before going to Bari sir, hello?
Hello, can you hear me?
Yes.
Hello? 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 Problem? Hello? Hello, Arif?
Dr. Arif,
Can you hear me, Arif?
unmute your speaker.
Audio বোধহয় disconnected হয়ে গেছে।
Sorry, we got disconnected for a while. Hamidul Islam, okay. There is question from the Golam Farooq
Yes,
sir.
yes, I was telling. Yes, I was speaking.
Yes, sir. Can you please repeat because we got disconnected, so that we need
Yes,
to.
sir. Question is regarding KR and Oliver.
Yes,
What is
sir.
your comment about KR Oliver? Actually, this depends on the quality of the wire. If we use the good quality wire, not a matter either maybe KR or Oliver. But one thing is very important here. We have seen in the Kurgan center that some of the professors are saying that we do not use the olive wire is without a specific location, because olive take more space, and a special metal are used in the olive, which is causing always irritation and the bone wire interface. So the more chance of infection in olive wire. So if it is possible to avoid olive wire, but in case of K wire, if it is good quality K wire, it takes less bone surface bones wire interface, so there is less chance of infection.
Before going to
Right.
Bari
Thank
sir,
you.
with the permission of Bari sir, I want to just add few things. Then I will go to Bari sir. Sir, for Golam Farooq sir, we have also two sessions. One session, Professor Bari sir will focus on the biomechanics of ILIZAROV surgery, ILIZAROV technique, and I think he also have comments about some implant properties. And you know that I have a lecture on what are the quality of recent implant manufacturing in Bangladesh and quality of the implant we are using. Sir, for your information, every ILIZAROV wire or the wire are so designed that it is very flexible, and its physical property, elasticity, and when the wires failed, there is a certain parameter. But in our country, we use the wires. These wires are very stiff and also the composition or the steel quality is not always medical grade. So maybe we use many low quality wires. So it is one of the very big problem for the ILIZAROV surgeon. And other very big issue in my clinical practice, or also you may admit that when we use olive, but in our country, all the olives are just shouldered with the copper materials, with stainless steel. These copper materials definitely do a reaction when it is kept for long time in the body. So it is the high time for us, please think about the quality of the wires. And also the one thing in this relation, the wires in Kurgan center, the olives tip are so fine and so nicely designed that it causes very less tissue reaction. But in our country, the olives are very much big in shape, the beats are big, and you'll cause definite reactions. and I am going to Mufakkal Bari sir. Please have some comments the overall presentation of Hamidul Islam, and also please address the issue of Ghulam Farooq sir and your comments, please, sir.
Okay. Good afternoon, everyone. From my country, from India, from Nigeria, and from Nepal, I see.
Nepal.
In every of my lecture, I always remember the address of Professor Shepsov and ILIZAROV all the time. Professor ILIZAROV and Professor Shepsov all the time was telling like this: no surgeon is justified to do any reconstructive surgery by ILIZAROV technique unless he has got the competent idea regarding the technique and the apparatus. This is methodology. This is not only putting the wires. ILIZAROV, this is mechanical thing and biological thing. And most of the orthopedic surgeons, ILIZAROV surgeons, they forget regarding the biomechanics of the ILIZAROV external fixator. Most of the orthopedic ILIZAROV surgeons. Why? Before applying ILIZAROV, you must know the biomechanics. And biomechanics is always related with the rings, with the wires, size of the wires, and tension of the wires, everything. If you forget the biomechanics of the ILIZAROV and principle of the ILIZAROV, you get a lot of infection in every cases. We are controlling infection by ILIZAROV apparatus, and at the same time, we are creating infection by ILIZAROV apparatus. We are treating non-union by ILIZAROV apparatus, and by ILIZAROV apparatus, we are treating non-union. And believe it to me, today I have seen 2 cases by telephone and WhatsApp. One of our colleagues, he has done this case, and there is a big gap non-union for the last 1 year. And patient is going to that, and doctor is telling you it will be okay, no problem. But I'm looking the X-ray. My son sent me this, give me the advice. So this is the things. So always keep in mind, no surgeon is justified to do any reconstructive surgery. I repeatedly repeat it, unless you have a competent idea regarding the apparatus and the technique. I myself now use all the wires and olives from Kurgan Center. And for the last, this is probably 7-8 years I'm using Kurgan wires. Why? If I don't use because wire plays very important role in ILIZAROV surgery, olive and wires. Proper tensioning, proper flexibility. The wires that we are using here, we are getting it from India and from my country wires. This is not the good. So first of all, I am violating the rule. And what you can say what to do. If you don't have good quality, you will not get good outcome. This is obvious. Regarding the paper, Dr. Hamidul fantastically elaborated everything. Last year, we had a conference in Assam in UK. There was a debate between the Kurgan and the Western world. No unique result. In Russia, they are using all the time. They have a vodka. They are using this strong antiseptic for dressing. And proper dressing, what I have seen, nowhere in the world except Kurgan they are doing it. And Hamid showed you one case, lady nurse that was doing the dressing, and you have seen how beautifully this is covered. And in our country, and I have seen in my neighboring country, where they are putting the ILIZAROV wires, they are not using the rubber stoppers. And again, you are violating the principle. Violating the principles. Please use rubber stoppers. If you go through the volume 2 Campbell, you will find this 11 edition or 12 edition, 106 page. I'm telling you, you can write. What about the importance of rubber stopper? And most of our colleagues, they don't use. Regarding some of the tricks and tips that Hamidul said fantastically, and I agree with that. Proper tensioning of the wire is very important. Every day you should have to check yourself by your fingers wire is tensioned or not. If not, And again, you should have to, with patience, you should have to tension that one. If you omit it, okay, problem no, no problem, it will no. It will invite infection. If loosening wire, you try to remove that one. If you see there is a edema, there is a redness of the surrounding the wire, then pus is coming, then you can go for 7 or 2 weeks, go for antibiotic. But if you see your wire is loose, you remove that one. And before applying this, all kinds of every tidbits you should have to tell to your patient. It may happen, it may happen, it may happen. It doesn't mean that you will get a bad result, no. This is external fixator. And fundamental principle always I'm telling, load and motion. Yesterday I was looking one paper from tract infection with physiotherapy. They were presenting from Kurgan Center. It was a very good paper like this. And it was pin site infection. This is not very common, but this is not a problematic for the orthopedic surgeons or the ILIZAROV surgeons. So quality of your apparatus is very important, especially the olive wires and the smooth wires. And if you put the shunts, pre-drilling is always important. Most of our orthopedic surgeons, they are using drillings directly. No, this is not advocated. This is not right. Pre-drilling is essential for the pins. In the upper femur, when you are using, please go for pre-drilling. And you must respect the soft tissue and as well as the bone. And with wire, when you are drilling, you are vibrating, there are a lot of bone powders. If you keep them under the skin, it will invite infection. So before finishing the whole assembly of the apparatus, you must see everything. Wire tension, properly, striving force around the ring must be equal. That's why you should have to use the dynamometer. Sometimes if you are expert enough, if you're confident that I can handle it with Russian technique, you can do that. But you should have to check with your fingers all the time. And some tidbits, stress on the wire bone surface can be reduced by using the accurate size of the ILIZAROV rings. If you don't use the accurate size of the ILIZAROV rings, you will invite again infection. Now, from the lecture of Dr. Hamidul, I have some little bit observations. Elaborately, nicely, he has mentioned everything. But see, that I told you, we always follow. I myself, I try to follow the Kurgan procedure. And I myself, I have my own something. I try to avoid the, I told you in several lectures, chlorhexidine you can use, but spirit dressing is very good. If you don't have a spirit, use normal saline. Don't pobicid iodine, don't use pobicid. Well, pobicid iodine, I'm telling you, don't use. When it stuck to the skin and a wire interface, when you remove this pobicid iodine, your skin, you know, that side, it becomes some problematic near the wire and skin interface. So to avoid that, you don't need to go for pobicid iodine dressing. And low speed drilling, dear friends, in most of the third world country, most of the orthopedic surgeons, they're using 2,500, 3,500 drilling. In our starting lecture, our colleagues, they told 800 to 1,200 RPM. Keep it in your mind. These are all things you must respect. Respect to the patient, respect to yourself whenever you are using these kinds of things. ILIZAROV is a vast thing. And biomechanics, technique, and proper use of the, when you are drilling the wire, you must fully soak the gauge, the gauge with which you are holding the wire, it must be wet. Because when you are drilling, you are doing thermal necrosis inside the bone. And to prevent that, slowly you go with full spirit dressing, then it also helps to decrease the infection of the pin tract. And unicortical huff pin, if you use, try to avoid that one, unicortical. Yes, and that will also reduce the huff pin. And finally, I would like to, don't want to lengthen it. You always counsel your patient regarding the proper patient's education. Patient's education is very important. If you don't educate your patient, you, the doctor, who is going to manage the ILIZAROV apparatus and long course of treatment, because you are treating the patient for the last 3, 4, 5, 6, or 7, even 1 year. So you just be patient with the patient and tell your patient, you will face these kind of problems. This is not infection. You know, illiterate people, even the literate, if something comes, you must tell them what I tell them. How many holes in your body? I tell the patient. How many holes in your body? Big holes? 7, 8 holes? What is coming from the holes? And how many small holes in your body? Sweating. So I have made the hole in your body. Something will come. This is normal, temporary, 6, 7, 8 months. Don't afraid of this. Whenever I'll remove the wire, everything will be okay. You must tell your patient like that. You're making hole, that is you're embedding something. Something will come from your hole, so nothing to worry. And at the same time, you must make a guideline for your local language, Nigerian language, or Bengali language, or Hindi language. You make a small book. Whenever patient comes to the place, you give the book that I have, that is published in American Journal also in Bengali and a little bit English, so that the people can understand in your local language you are. Whenever patient gets admitted to your place, you give them, this is your book, you must read, and I will ask you some questions. You should have to answer all the questions. You understand me? So this is the overall, you must be meticulous with the apparatus, meticulous with the patient, and everything. These are the things that I wanted to tell you. And thank you very much, Hamidul, again, elaborately. He has shown the beautiful legs, Russian legs, and Bengali legs. Everything is okay. Thank you very much for your
Thank you, sir.
Thank you,
patient
sir.
hearing.
Thank you, sir. So everyone got the idea that not only the particular things, you have to just be careful about many things during doing the ILIZAROV. And sequentially in our webinar session from the first day, 17th of last month, we are trying to deliver you all the things so that you can get all the idea. And with the permission of Bari sir, I want to show few 3 or 4 slides because you told that patient counseling and patient education is very much important.
Yes, you sure.
Yeah, patient very much important. So it is our duty to just accommodate our local resource and how we can deliver the patient a good level of care, and also how they can manage their dressing at their home. In Kurgan Center, we have seen that they do not allow patient to do their dressing. But in our situation, in this subcontinent, we have to compromise for certain things. But we need to more meticulous, as the patient is with the ring for 5 to 6 months. Patient usually get very much educated and get mastered of many things. So we can deliver this technique to the patient so that patient can very nicely care of their wires. And now I'm showing some few things. As the Barisar told that patient education is important, I am sharing my screen. Can you see my screen?
Yes.
My take. You got that?
Yes.
Okay. Now I'm going to the slideshow. And usually every time we need to think innovative, and as you see, heard from our professor that he have a small book for the patient, so that patient can go through. And I have a different idea. I have a online platform, as because patient most of the time in the online platform, they spend time in the YouTube. So you can have your YouTube channel, or for your particular patient, to orient the patient, so that patient, you can upload your dressing video, a ideal one, and you can advise the patient. You can go repeatedly for your problems, and see how the dressing is doing in our center, and you can go through, so that you can have a good dressing care. And now the ILIZAROV clinic, and you have to set up ILIZAROV clinic, because you have to spend more time in your patient, so that you can organize all the things, you can check the wires, and you should tell the patient to come frequently in your center, so that you can organize all the things. And every ILIZAROV surgeon should have this type of organization, so that he can go close to the patient. And this is my modification. This is our autoclave pouch. And you know that in our rural condition, getting the sterile gauze piece in the local setting, except in the hospital or clinic, is a very difficult one. And to maintain the sterility of that gauze piece is very important. You just tell your patient to do the dressing, but you do not organize how to get this type of gauze piece from his settings. So I just collect this type of autoclave pouch. Autoclave pouch is very familiar to the Western world, and many surgical, and even like the disposable syringe, everything is ethylene gauze, ethylene treated, and it is make sterile. But here you can do autoclave. It is autoclave pouch, and you can get just 10 autoclave pouch with 10 gauze piece in number, just in $1. That means that in Bangladeshi taka you can get. I just request to everyone, please mute your microphone, so that the noise is less. This autoclave pouch just cost about the 8 taka in Bangladesh, or 8 rupee in Indian rupee. So you can give your patient a frequent interval when he come to you, so that patient get the gauze every time in his local setting. And this was my previous technique. This is a milk can. Everybody in the subcontinent is very much familiar with this can. And I make the gauze autoclave and put it in can, and ask the patient to take one roll every time of dressing. But usually patient make it contaminated. So now I am turning to the autoclave pouch. And this is another view. And one important thing is that you must have the cover your ILIZAROV frame so nicely, so that the dust and other, as if our local environment is humid and there is very much dust is there. This type of cover is very much essential. And thank you all. This is some my tips regarding how can we provide the better care to my patient. So I am going back to the presentation, and I will go to some of the participants for their recommendation. Yes, sir.
Arif, regarding this for the foreigners and our local, just I want to show that one my publication. What that a little bit, only 1 minute.
Yes, sir. Screen share. Screen share is open.
I'm sharing. Have you seen this one?
Yes, sir.
See, look. This is for the foreigners or from my local doctors. You can read it. It was published in 19 September 2017. And then you can see here figure 1. This is what I have written here. ILIZAROV fixator, patients, tibia, showing common scenario in which wire may cause risk of infection. And now you can see next
Sir,
page.
Can you make large
I'm making it.
magnifying? Yes, sir. Magnifying the photo you have shown earlier.
132. Wait. Okay.
Sir, here is a plus sign. If you just click on plus, it will.
Okay.
Plus sign or.
No, you will they can download it and they can read it. Wire tract infection.
Hello.
In ILIZAROV. Now see, wire tract infection technique, how to manage that. Now look at this. This is the book written in Bengali and English, and see how I have hold this gauge, weight gauge, and this is the shunt. You put rubber stopper.
Sorry, sir.
Whenever you shunt,
we cannot see your screen, sir.
Why?
Just one place it is stopped. One place. Can you do the sharing again, sir?
I'm doing. Wait.
Sir.
Oh. Is it visible?
Yes, sir. Yes, visible, sir.
So shows how to hold the wire with the soft gauge during treatment. Okay.
Yes, sir.
Now see to the right side. ILIZAROV instructions for ILIZAROV patients, trauma and orthopedics. Then
yes, sir.
Figure. Then you can see we are always following the original Kurgan principles regarding wire insertion to avoid heat. Here is the 4 things that I told you, and Hamid also told you. Yes, and sir. In conclusion, see a little bit I have given the idea so that you can have idea how to control, and the way that you have shown, that is good. Rubber mast, rubber stopper mast. These are the basic principles. Thank you so much.
Thank you, sir. Please stop your sharing and we can go to the gallery view. And now I am going to a different participant. There are many renowned participants here, experienced surgeons, and for their experience about Pintact care. And also I will go for the question also. Some of the participants send the question to me.
I see Shatish. Yes, Shatish is here already. Shatish.
Yes, sir. Shatish sir is here. I am going to Shatish sir for Shatish sir. Can you hear me, sir?
Yes. Yeah.
Sir, today our topic is Pintact care. So it is a very debatable issue, different corners of the world. So what is your Pintact protocol, and have a comments over how can we increase the patient caring of Pintact or Wiretect care during the ILIZAROV fixation time?
Already Bari sir has beautifully covered so many important points, how to manage the Pintact infection, how to prevent it. So fortunately today only I operated a few hours back one patient. So I will narrate the things, how things go on. 3 months back I operated tibia ILIZAROV, proximal tibia fracture, and I did excision of the necrotic bone, removed the plate, did the excision of the necrotic bone, did a distal corticotomy, and started the bone transport. So because of the lockdown, patient did not turn back. So here what we can learn is proper follow-up is very important. And the second point what I noticed in my patient was he didn't turn the rings, turn the nuts properly. So because of that, there was loss of tension in the wires, and the whole assembly become very loose. So this is one of the major cause for infection of the pin tract. Whenever the fixator becomes loose, the wires or pins get infected. The infection of the wires and pins are very common. So this is what I noticed. And one more thing I want to add to this point is, once our work is done, that is the bone transport is complete. So what we have to do is, we have to maintain the tension of the wires. So how do we maintain? By turning doing a 1/4 turning Monday or Sunday and Wednesday. 1/4 turning once a day, Sunday and Wednesday. So this is how I do it during my on my patients. I hope Baris sir agree for this.
Yes, thank you.
Yes, sir.
Good elaboration.
And now, thank you, Shodish sir, for your nice comments and your sharing experience. And now is a question from Ghazi Hassanul Munir. I will go to him just a couple of minutes later. So now I'm going to Amir sir for your experience share regarding the wiretech care. Amir sir, can you hear me? Just he got disconnected. And now the question from the Ghazi Hassanul Munir to Hamidul Islam, importance of crust around a pin tract. Hamidul Islam, got that question?
No, crust.
Yes, yes.
Actually, crust or scar. Crust, if there is crust surround the pin,
Yes, sir.
pin during the, and we should not try to remove the crust forcefully. If we remove the crust forcefully, there is chance of more such infection is there. Crust will remove automatically. When it will heal, it will automatically remove.
Usually this crust around that pin tract, most of the author just advise not to remove it because it has some protective properties, and if you just remove this, it will cause the raw pin tract area, and it will increase the chance of infection. The crust also, usually when you see that when the blood is clotted, there is a formation of fibrinogen and other type of complex protective mechanism is there. The crust around the wire is more or less likely that it also protect your area of exposed skin from the infection, and it is not the infection, and so the crust should not be removed. And now I am going to another question. Dr. Rashida Rani, I have two questions. Just please unmute yourself and you have your question to the speaker. Rashida Rani.
Thank you, sir, for giving me the chance. First of all, my respect to Professor Bari sir and to other also. I thanks to today's president, Hamidul Islam sir. I have a question. After removal of ILIZAROV ring, if there are persisting pin tract infection, then what can we do?
Yes, it is very common factor for us because there is every chance of persisting infection after removal of the wire. One of the protocol is that after removal of the wire, you should check for each pin tract site, and you must adequately clean and adequately debride the each pin tract care. And if you think there is a big hole or there is a chance of infection, you must observe the patient frequently. And patient is that you must advise some antibiotic for 2 weeks or more, and follow the patient. If there is chance of osteomyelitis, and if you think there is like that, you must do an X-ray of the patient. And if there is osteomyelitis, persist osteomyelitis, there is some change in the bones, and then you can retest the bone if there is infection or osteomyelitis.
Okay, thank you, sir. In this issue, I will go Amirusan sir and then Bari sir. Sometimes we get still discharging sinus. Even patient come after few months, some discharging sinus from the pin tract. It is very rare, but it many times it happens. and what you do in your clinical practice. Please share your idea and also your Pintract caring technique. Please, Amir sir, if you hear me, please have a comments on this.
Yes. Thank you, Dr. Hamidul Haq. You elaborately mentioned the Pintract infection, which is very common to day-to-day practice with ILIZAROV surgeon. And I think Bari Bhai rightly said that pin quality is vital, and also for our side, for the surgeons, the must tension adequately. Otherwise, pin tract infection will be very common. Now, for the Ari's question, I think if there is a serious infection on the pin tract, Paribhai already said, and I am agreed, please change the pin from very little above or below, remove the pin and again start insert the pin again. And this may be a solution, and also from the pin side, which is more infection, we may culture them and send for cultural sensitivity, and accordingly antibiotic may start it, and also dressing. But one thing, Bari Bhai already said, why not providinidine? I think providinidine also a good antiseptic for pin tract infection management, like chlorhexidine, alcohol, and others. Thank you.
Thank you, sir. I'm going to Bari sir for also the question regarding the when the persistent pin tract infection after the removal of the wire, what is your strategy? And please have some comments on Amir sir advice, what is bad with the povidone. Bari sir, can you hear me?
Yeah.
Sir? Yes, sir.
In this is in everywhere, in femur or in tibia. Femur goes quite different, tibia goes quite different. If you think about the radius ulna, quite different, depending on of your location of the bone. In general, I'm telling you, whenever you are seeing that there is a lot of pus is coming, pin is loose, Amir Hussain told, remove this one. Even one or two, remove and place in another place. Proper wire tensioning. See the whole stability of the whole ring, other wires above and below, stability, and then proper dressing, proper dividing. Even then, if it doesn't cover all these things, then you should have to think yourself, then remove the ring in that side, open up, clean, and then you can go away. This is especially for the adult. Big. For children, you don't need to do all these things. This is my experience, and this is my teaching that I have seen. And that's why infection burns in the fire of regeneration. This is 100% absolutely true for the children. But for adults, big secret stuff, sometimes you need to go for in that region in the focus, then you should remove that one for the adult. So this is the common thing. And experience makes a man perfect. When you do, you'll take decision what to do and how I can overcome all these things. This is the basic thing.
Thank you, sir. And we are also trying to take all the important information from you, as you are most experienced ILIZAROV surgeon among us. And I think Rashid Hassan Rani have another question also. Rashid Hassan Rani, can you hear me?
Yes, sir.
Yes, sir. What is the second question?
No, sir. I have no more question.
Okay, thank you. Thank you, sir. And now I am.
Ken, he is raising hand several times.
Yes, sir. I am going to Ken, sir, and now I am going to Major SM Iqbal, sir. If you hear me, Ken, sir, I am coming to you. Just a couple of minutes later. Coming to you, sir. Iqbal, sir, can you hear me?
Yes.
Yes, sir.
Can you hear me? Yes. It's actually a very yes. Can you hear me?
Okay, okay, sir. You can continue. Yes, sir. Ken, sir.
Yes, honestly, I've learned a lot from this session, and I never knew that cross actually has a protective effect on the pin tract infections, and I've learned that today. I have no questions actually. It's only to commend the presenter and the rest of the Kurgan group, Kurgan fellow group. Thank you so much.
Thank you, sir, for every time you are always with us, and please stay connected with us. We are just coming with more and more exciting things later on. And now I am going to Major SM Iqbal sir. Sir, can you hear me, sir? Iqbal sir, can you hear me?
Sir, I'm hearing you.
Yes, sir. Sir, you know that today the discussion about PINTACT care. Can you please share your experience regarding the PINTACT care, and what is your recommendation or overall the presentation?
The presentation is very nice, and I'm glad with the very renowned person's comments.
Hello, sir. Oh, okay, sir. Thank you. And I think if we don't have further no more questions, we can go to different participant for a few minutes. Then we can conclude our session. And before concluding our session, with the permission of Bari sir, and also here is Shoti sir, Amirushan sir, the senior professor are here. So I want to just give some message to the participants, so that what we have discussed regarding how the ideal our PINTACT care. So if we take it as a take home message or as a stay home message, that is, Bari sir, please just when PINTACT care, usually every ILIZAROV surgeon should have a very strong and delicate knowledge about all his apparatus that is he is using. And the in Kurgan Center, Novikov sir used to tell us every time that when you have respect to your dignity, usually every clinical practitioner have create his image on his local area. He has a good fame and good dignity. But in ILIZAROV technique, you have to maintain this dignity. Don't compromise with the quality of wires, quality of wire tensioning, or quality of dynamometer. If you make it compromise, then you will compromise your dignity and your fame. So ILIZAROV technique should be a very meticulous one. And in regarding PINTACT care, usually Kurgan Center do not allow the patient to do their dressing. But in our situation, we can customize it. We can allow the patient to have the dressing with a little bit modification and make it more sterile. You can have give the patient the better idea to get sterile gauze piece. And usually we recommend 2 to 3 days 3 days cycle turn or weekly cycle for changing the dressing. If any wire is got infected, you can change it as it needed. And usually dressing should be done with chlorhexidine in our setting. Better to use the spirit or rectified spirit, and other additives is not seems to be it is very much superior to other. Somebody just can use only the normal saline also, and don't put any additive in the gauze piece left in the pin area. Only use the dry gauzes, and use the covers also. And when there is infection, do accordingly what is the recommendation. And regarding shower, I want to go to Bari sir. What is your recommendation in my clinical practice and in our situation? Because our implant quality is not good enough. Sometimes it get rusted and it is produced not from the medical grade stainless steel. So I do not recommend to take shower in saline water or in iron water or tube oil water. So patient can clean as much as time in his rings he can, but I do not suggest the showering of the patient. So what are the comments I make the on overall overall discussion? Bari sir, can you please have your opinion on this, and we will go to the next part. Yes, sir.
Another thing we have not mentioned here properly.
Yes, sir.
Some well locations of the wire, such as the periarticular region, have increased the soft tissue swelling, periarticular region, around the wire, yes, which will lead you irritation at the pin site. This is important, periarticular, near the joint, okay? And rubber stopper, please. This is very good thing, rubber stopper. Try to press that one with skin and wire interface, this one. And regarding your shower, I tell the patients, those who are illiterate, coming from the village, I tell them, you take hot water, big bowl, hot water, then yes, cool it, and with that, in a week, one time, full shower the whole apparatus. Yes. And then I advise them, take packet gauze, surgical gauze, wash your hand properly with soap, just like a coronavirus. Wash everything and non-touch technique. And cut this scissor that we are going to use. Also wash it with spirit, alcohol, everything, and then cut. Then just like full coverage of the whole, every ring, the wires. Not only the below the rubber stopper, just cover so that it looks nice. Looks nice. If you believe it me or not, I don't know. Whenever patient comes to my place, sometimes it happens without any gauze in the tibial ring or in the radius ulnar ring, I give them the punishment. Go, I will not see why you are not following my instruction. You go outside, I will call you later on. Then smoothly I tell him, if your door, all the doors are open 24 hours, what will happen in your room? This is my room. This room is blocked. AC is going on. If all the doors are open, what will happen? 24 hours open, what will happen? Then patient is telling, sir, infection will become, this all jams, everything. Same thing with you. Then, sir, sorry, sir, I'll not do it later on. And this is the teaching. This is not for one-day teaching. This is not for, at counseling, you must talk with the patient. Psychological support. Pain, sometimes patient, lot of the patients, sir, this is a burning sensation. It's okay, fantastic. I tell them, fantastic, it's good. Burning because new regeneration. Sir, pain. Bone is alive, there's no pain. See the dead bone, no pain. Your bone is alive, come in. Okay, sir, thank you, sir, thank you, sir. Nothing else. These are the teaching. You must talk with the patient. Always. Thank you very much.
Thank you, sir, for your kind information that we always believe you and always follow your technique. And the same words we used to say in our clinical practice. If you come without in my chamber practice room without any gauze piece, I will just keep you get out, and you cannot have my consultation that day. So we just want the patient every time, sir.
We're doing the same.
Good.
It is the lesson from you, sir. It is the
Thank you very much.
Thank you from you, sir. And today, my two co-hosts, a little bit just offline today, Ghulam Mustafa and Nazmul Huda Shetu. Can you please come on the platform and have
Ghulam Mustafa is not talking?
Yes, my net is very weak, so I cannot connect with him. Sometimes we can disturb.
Okay, sorry, sir. Then can you please have some comments?
Yes, I also follow my sir's principles and the technique, and I usually after the operation, just I give the dressing properly, and the patient advised to not to touch this for the next 2 weeks. Then after come to the 2 weeks, then we change the all gauze piece, and then we try to wash this again with the normal saline. Then we do the dressing properly. And another thing, the crust, if there is any crust, I do not like to remove the crust. Keep it in at the base of the paint. And I think it is a huge amount of immunoglobulin cell, so it protects the organism, so it helps us. Another thing, during operation, in Kurgan, we see everywhere before insertion, they use separate gauze piece. No separate gauze piece for every wire. And they use the gauze piece in the dressing stopper, dressing fixed with the rubber stopper. And at last, at the end of the operation, the whole limb is washed with the normal saline, clean the all debris, bloods, and the staining, everything. They clean it as a normal skin. Then do the dressing properly, and and I try my best to do this principle, and I think it is better. Please, thank you, Arif.
Thank you, sir, for sharing your experience. And usually for proper pinta care and a universal pinta care, everybody trying to follow the Kurgan principles. But the Kurgan Center also trying to make a universal protocol. I think within years or in the and some next coming years, we can get the universal protocol for all over the world for proper pinta care. And now I am going to Ghulam Mustafa. Ghulam Mustafa sir, can you please have some comments? We are at the end of the session, and we will go sequentially from Ghulam Mustafa sir to Shoti sir.
Arif sir, can you hear me?
Mufakkal Bari sir for ending the session, and then Samsunuddha sir. Okay.
Arif sir, can you hear me?
Yes sir, I can hear you.
Okay. Thank you, Dr. Hamidul, for your nice presentation. You nicely and elaborately presented everything. And during the discussion, we got a clear conception about our pin tract care. And I generally, during the staying of the patient in the clinic or hospital, I do dressing every day. And when I gave discharge to the patient, I myself teach the patient how to dressing it and take an examination, and they do in front of me. When I satisfied, then I let them the pin care or dressing twice weekly, or if there is any discharge from any pin tract, do the dressing daily. And that's all. Thank you.
Thank you, sir, for your nice comments and also sharing your clinical practice. One thing I want to just add in relation, the Ghulam Mustafa sir nicely tell about he spent a good amount of time post-operatively with the patient to educate the patient regarding the dressing. So every center or every ILIZAROV practitioner should have this type of motivated team who can teach the patient how to do the dressing. It is very much important. After operation, you have to spend a very good amount of time with the patient. Otherwise, the patient will not be motivated, and patient goes home without have any good information. So this patient will create the complications. So now I am going to Shotish sir. Shotish sir, it is we are at the end of the session. Do you have any conclusive comment regarding this session?
Yeah, Dr. Arif, I would like to add some of my points. So when a patient comes to me in my OPD, ILIZAROV patient, when it comes to my OPD with pin tract infection, so what I do is initially I clean up the pin tract, the site, I clean it properly, and then with the help of a spanner, I just strike it like a tuning fork. I just strike the wire. And if the patient complains of pain, So this pain might be because of infection and also because of loosening of the wire or loss of tension. So next step is I tight all the nuts and bolts of the apparatus, and then again strike the pin or a wire. Even though after doing this also, if the patient have pain, then I retension the wire in the OPD itself with the help of tensioner.
Yes, sir.
And after that also, if the patient has pain, then I take a taxim powder or a ceftriaxone or a cefotaxime powder and then spray it around. Sometimes I also use a gentamicin injection to inject around the pin tract. So this is how I do. And many of the time I come out with good results with this technique. So I'm quite happy with this technique and I do this. And sometimes if the pain is too severe, even if after doing this injection technique, dressing, if the pain doesn't subside, then I will replace the wire in short anesthesia or depending upon. Yeah, this is my protocol. So I think, sir, Bari sir, what is your comment regarding using antibiotic powder or gentamicin injection to inject around the
gentamicin, Satish, gentamicin is very good, very less costly.
Yes,
I go for around that. Even I wash with 3 ampoule, I take a step.
Yes.
3 ampoule 80 mg adult.
Okay.
This is written, this is published already in UK journal. 3 ampoule gentamicin stat, and sometimes infected, I take 10, even 15 gentamicin. Then I wash with gentamicin.
Okay, nice, sir.
These are the tidbits, These are you can apply, no problem.
Yes. Thank you, sir, Satish sir, for sharing your experience. Also, bringing forward topics about the injection of gentamicin at the pin site. Now I am going to Mufakkal Bari sir for your concluding comment, and I am requesting Samsuluda sir. I am going to you after Mufakkal Bari sir, and before going to Mufakkal Bari sir, I want to just announce that tomorrow is a very important session for us. Most senior professor in the subcontinent in orthopedics and ILIZAROV technique, Junjunala sir. He is a ex-president of Assami and also IO India, ex-president, and he will deliver his experience regarding the congenital pseudoarthritis of tibia. Everybody, the ex-union protocol of Dorpele, and for pseudoarthritis, we have to keep open our eyes and know the more, because many things to discover, and also the accepted non-union. And now I am going to Mufakkal Bari sir for your concluding comments, and if you want to add anything, and you can add with us. Mufakkal Bari.
Thank you very much. Not possible in one lecture add everything. Gradually. In ILIZAROV technique, everything must be done gradually.
Yes, sir.
Gradually. Yes, this is the principle. And love ILIZAROV. I always tell ILIZAROV is just like aeroplane. And love ILIZAROV just like as you love your wife, spouse. Yes, then you will get a very good result. You should have to, because you are staying with your wife all the time. Okay. And same, you should have to stay with ILIZAROV all the time. Yes. With honesty, dedication, sincerity, devotion. Then you will have a very good. Thank you, Satish. You've joined with us. Thank you very much. And all Nigerians. Okay. Yes. Thank you, my junior colleagues. They were my student, not they were colleague. Problem? Thank you. I'm very, very happy. Thank you very much.
Thank you, sir. You are always inspiring. And,
yes.
Always makes us to think differently. And it is also a very positive point that sincerely, I will tell one thing is that for this ILIZAROV Kurgan Fellow, Bangladesh Kurgan Fellow Group webinar, you spend so much time with us, and also our phone. You give us very important time of your daily day-to-day time. So I am very much thankful to you. You are always with us, and I think this bondage will.
Why I am doing that? I need your dua. I need your dua. That's why I'm doing like this. Okay, dua, please dua. Oh, Satish.
We always pray for you.
We always keep you in our prayers, and also
thank you, please.
Please
Okay.
extend your blessing over us. And now I am going to Samsuluddha sir. Samsuluddha sir, can you hear me?
Yeah, Dr. Arif.
Oh, sir, I think you are in our discussion. Sorry, sir. Can you please make some comments about the Pintact Care overall session, and also I am delivering the host status to you. Are you, sir? Are you connected with me, sir?
I'm very sorry for because
you know that Samsuluddha sir is doing a great job for us for bringing this platform in the last.
Very interactive, so I'm not starting. I'll just stop the live session.
Okay, sir. You can enjoy it also in the YouTube, as you are also uploading this in your YouTube channel and also in ILIZAROV Clinic YouTube channel. Sir, Samsuluddha sir, if the connection is steady, then I will make you the host so that you can end the transmission. We are waiting for Samsuluddha sir because you know that this is live on YouTube on Ortho TV Live, and every day in our session Samsuluddha sir, Ashok Sam sir are doing this job. So I am waiting for Samsuluddha sir for the connection. And you know that we have 7 or 8 lectures left, and we'll end our session on 24th of this month. And that session will be a very big one, and some of the new speaker can be added in between. So I will let you know when we make it possible. And you already know that tomorrow Junjunala sir will be with us. Yes, Samsuluddha sir, can you hear me, sir?
Yeah, please make me host so I can end the live session. My date is very rapid.
Yes, sir. I am making you the host, sir.